हेलो फ्रेंड्स, वेलकम यू ऑल एट इंडियन इंस्टीट्यूट ऑफ लर्निंग लाइफ सेविंग स्किल्स। आज हम बात करेंगे एक बहुत ही महत्वपूर्ण विषय पे जिसका क्रिटिकल केयर में काफ़ी ज़्यादा इंपॉर्टेंस है और टॉपिक का नाम है शॉक। यस, आपने सही सुना, शॉक। अगर आप इमरजेंसी डिपार्टमेंट में या क्रिटिकल केयर में काम करते हैं तो 10 में से 2 या 3 या 4 पेशेंट आपको शॉक के ज़रूर मिलते हैं। वो कोई भी शॉक हो सकता है, ट्रॉमेटिक शॉक हो सकता है, कार्डियोजेनिक शॉक हो सकता है, न्यूरोजेनिक शॉक हो सकता है, डिस्ट्रीब्यूटिव शॉक हो सकता है, मल्टीपल कंप्लेंट्स हो सकती हैं। तो सबसे पहले हमें समझना है कि शॉक है क्या, एग्जैक्टली शॉक में क्या होता है। तो शॉक इज़ ए सर्कुलेटरी कोलैप्स of varied etiology, or it is a constellation of sign and symptoms characterized by hypotension, tachycardia, and anaerobic respiration and hypoxemia of the distal cells. Both oxygen and glucose levels falls down to the distal tissues. In response, they produce more number of lactic acid, further worsening the shock. So shock in toto, we define shock is a clinical syndrome characterized by hypoxemia of distal tissues characterized by low oxygen and low blood circulation to the tissues, production of anaerobic respiration and leading to lactic acid more production leading to shock. So basically shock, when we tell patient is in shock, usually systolic blood pressure will be less than 90 mm of Hg, or MAP, that is mean arterial blood pressure, that is diastolic blood pressure plus pulse pressure divided by 3 has to be less than 60 mm of Hg. So when we talk about the shock, so best inotrope in the shock. So which is the best inotrope? So first of all, any patient comes with a low BP. So first we need to rule out whether patient is having hypovolemic shock or it is a non-hypovolemic shock. So hypovolemic shock, usually it could be hemorrhagic or non-hemorrhagic. Hemorrhagic means there might be a history of trauma, and in trauma hemorrhage might be concealed. Concealed means internally there is a bleeding inside the internal organs, in the chest, in the abdomen, in the pelvis, or inside the bones. Second, there is a visible hemorrhage. There is a open wound and bleeding is there from that wound leading to hemorrhagic shock. Second one, non-hemorrhagic shock, but it is hypovolemic. Total volume has reduced. That might be because of acute gastroenteritis, heat stroke, then burn, then diabetic ketoacidosis, these kind of cases where there is excessive polyuria, these condition, then hyperglycemic hyperosmolar syndrome, HHS. So in these conditions, when we talk about, when we are dealing with patient management of shock, so the best first thing is we have to give the fluid challenge. Fluid challenge means we have to give 500 ml to 1 liter of the crystalloid, that is NS or RL, to the patient, rush, and while checking the basal craps in the patient. If patient is developing basal craps, then don't give much of the fluid, otherwise patient will end up into respiratory arrest or respiratory distress, or end up into ARDS. So for this condition we have to check basal craps or examine the chest, and we have to give the fluid to the patient after one challenge, that is 500 ml. See how to rule out when the patient is in a low ejection fraction. Patient is having low ejection fraction and patient will be having hypotension. So volume will be very good and volume will be very high. When you check the pulse, pulse will be bounding and you can feel the pulse very nicely. In that patients usually will be having low ejection fraction. So that is most important. When there is a ejection fraction is normal and patient is in hypotension, usually will be weak and thready pulse. So first we have to give the fluid challenge, and the best inotrope to use is the noradrenaline. Best inotrope to use is noradrenaline, followed by we have to use dopamine. But contraindication to dopamine is when the patient is already running tachycardia, because dopamine causes all tachycardia. Then dobutamine has to be used in the patient when we talk about the cardiogenic shock. So there we have to use dopamine. And the last resort we have to use is epinephrine. When we have used noradrenaline, dopamine, dobutamine, nothing is working, then we have to shift on to epinephrine. So this is how we have to manage the patient of a shock when it comes in the emergency department or critical care. So the best inotrope to use is noradrenaline safe. Then one more responsibility of the critical care person or emergency physician to find out the shock, which kind of shock, whether it is a cardiogenic shock patient is having MI, acute coronary syndrome, underlying some rheumatic heart disease, mitral valve prolapse. Then distributive shock. Distributive shock means there will be trauma to the spine, neurogenic shock. Then there is a some kind of allergic reaction, anaphylactic reactions. That is also a distributive shock. Then we have to check for any hemorrhage in the patient, that is hemorrhagic shock. We need to find out septic shock. So this is the classification of shock, and based on that we have to manage the patient. So thank you very much. Keep connected with Indian Institute of Learning Life Saving Skills for these health updates. Thank you.